The government is terminating a $9.8 billion program that kept your drug prices lower. They announced it on a random Tuesday when almost nobody was paying attention. The headline screamed that Medicare Part D is collapsing. That is not what happened, and by the end of this video, you'll understand it better than the people writing those headlines. I'll show you the one number that triggered the panic, the $9.8 billion program that most people never even knew existed, and why 15 brand name drugs, including Ozempic, are about to get dramatically cheaper at the exact same moment. Stay with me here because the mistake that could cost you $1,000 next year is the one that I think many people are about to make. Here's what you'll walk away with. Exactly what changed on July 28th, whether you will pay more in 2027, and the 4 steps you can take this fall so that you don't overpay. If this channel helps you cut through the noise on aging, caregiving, and related matters, please do one thing for me. Subscribe and follow along and share this with someone on Medicare that you know. That share might save them from a very expensive mistake. For background, I'm Neal K. Shah, a Johns Hopkins and NIH-funded caregiving researcher and the CEO of CareYaya. I've helped thousands of families navigate aging and dementia and serious illness. I'm not a clinician, but a researcher and innovator in caregiving, and I read through all this news so that you don't have to. First, Part D is not going away, and your coverage does not vanish on January 1st. What's ending is a temporary program, exactly as it was scheduled to. The government spent $9.8 billion over 2 years to keep your premiums artificially low, and the Government Accountability Office found that without it, premiums for people who would have stayed put would have nearly doubled. This only touches the roughly 25 million people in standalone drug plans on original Medicare. So if you're on a Medicare Advantage plan, this particular story mostly won't apply to you. On the same calendar that the subsidy disappears, 15 negotiated drug prices arrive, cutting some sticker prices by more than 70%. The single most important number in this entire debate, your actual 2027 premium, hasn't been set yet. Which means anyone quoting you a figure today would just be guessing. So now let's get into the details of what happened. When an announcement comes out of Washington, D.C., 2 things are often true. Day one headlines overstate it, and the truth is usually less scary than the panic suggests. But occasionally it is more scary. So on July 28, 2026, the Centers for Medicare and Medicaid Services, CMS, that's the agency that runs Medicare, released its yearly Part D numbers. And buried inside that was one line, the Part D Premium Stabilization Demonstration. That's concluding at the end of 2026. It's a temporary program ending, returning the market to what CMS called traditional market conditions. So what was this mysterious program? For 2 years, 2025 and 2026, CMS paid standalone drug plans to hold their premiums down to cushion their losses. In 2025, it knocked $15 off the base premium and capped how much any plan could raise your premium at $35. In 2026, it scaled back to a $10 reduction and a $50 cap. Nearly every standalone plan in the country signed up. And the number that'll surprise you is that $9.8 billion number. That's what the Government Accountability Office says this whole program cost. The GAO also found something remarkable, that without this money, premiums for beneficiaries who stayed in their 2024 plan would have nearly doubled on average. So it wasn't a small nudge, it was a very large, very expensive hand on the scale. And now that hand is being lifted. Which raises the obvious question, why would premiums have doubled in the first place? So hold on to that thought, because to answer it, we have to go back to a law with the most ironic name in Washington. The Inflation Reduction Act of 2022. Let's set the politics aside. What matters is what it did to your drug coverage, and most of it was good for you. It eliminated the donut hole, that dreaded coverage gap where your cost used to spike in the middle of the year. It created a hard cap on what you pay out of pocket for drugs, $2,000 in 2025, $2,100 in 2026. For millions of people, that cap is the difference between filling a prescription and skipping it. But every gift has a bill, and someone has to pay it. The law shifted a much larger share of drug costs onto the insurance companies. When you suddenly make insurers responsible for billions that they weren't on the hook for before, they do what typically businesses do. They raise premiums, or they drop plans, or they cover fewer drugs, or they just leave. And I think that's the real story behind every scary Part D headline over the last couple of years. The vanishing plans, the rising premiums, the disappearing agents, they all trace back to this one shift. So the subsidy wasn't really a disease, but it was a painkiller. And now the painkiller is wearing off. Here's a piece of history that I think makes this whole fight click into place. Before 2006, Medicare didn't cover outpatient prescription drugs at all. Part D was signed into law by President George W. Bush in December 2003 and launched in 2006. And that notorious donut hole wasn't an accident. Congress deliberately engineered that to fit the program under a budget number. So it's never really about the healthcare, it was about the math. And then what finally killed the gap was that politicians built it on purpose almost 20 years later. If you're finding this useful, this is a great moment to subscribe and follow along because most people will never learn where these rules actually came from. Now, the scariest part of all this isn't the premium, but it's the choices that are vanishing. A couple of years ago, there were 709 standalone Part D plans nationwide. In 2025, that dropped to 464. In 2026, down to 360. 22% decline in a single year. In 2025, the average person had around 14 standalone plans to choose from. This year, 11, the fewest since Part D began. And the people hit the hardest are the ones with the least. There's a special category of premium-free benchmark plans for low-income beneficiaries. These plans fell from 126 nationally to 90, then to 88, the fewest in the program's history. Some states are down to a small handful. When you have the least money and now you're getting the fewest lifelines, that's really the cruelty in these numbers. So who's left? Big names like Elevance, the company is Anthem, but they exited its standalone drug plans too. Cigna's plans were cut back. Aetna consolidated. They didn't leave the business entirely, but redirected it, pouring their energy into Medicare Advantage, where the economics are friendlier. Nearly 25 million people are still standing in the standalone Part D market, but slowly the tide is going out. So now that the subsidy is shrinking, the market is shrinking, and the costs are shifting. The obvious next question is the one that actually matters to you. Will you pay more in 2027? So, the honest answer here is nobody knows yet. And here's why. On July 28th, CMS released two numbers that sound terrifying, but mean almost nothing to your wallet. The base beneficiary premium is rising to $41, up to $34 from $38.99. That, less than a cup of coffee, but that crisis is what's launched a lot of panicked headlines. The national average bid came in at $296. Neither one of those is your premium. They're inputs into a formula. Your real plan-specific number won't be published until mid to late September. So the useful answer here is watch for the signal, not the noise. CMS Administrator Dr. Oz said that premiums will go up by less than $10 for most. But the administration's own bid data, reported through the press, tells a more complicated story. Roughly a quarter of people flat or lower, about a third under a $10 increase, and close to 45% face an $11 to $20 monthly increase. So most standalone members will likely pay something more, but it's not going to be double, not catastrophic, but nonetheless it will be more. Last year, analysts predicted a similar spike for 2026, and for many plans it didn't materialize. So right now, treat every 2027 prediction with a healthy grain of salt. The truth will arrive in September. Now for the part that almost nobody's connecting to the story, and I think it's genuinely good news. On January 1, 2027, 15 expensive brand name drugs get their first ever Medicare negotiated prices, and the cuts are steep, about 44% on average versus 2024 sticker prices. Drugs like Ozempic and Wegovy, the names that you've heard everywhere for weight loss drugs, negotiated down roughly 71%. Trelegy, a common breathing medication, down from $654 to $175. A diabetes drug down from $488 to $78. So those are huge, huge drops. But I'm going to be straight here. Those are the prices Medicare pays, the maximum fair price, not necessarily what you may pay at the pharmacy counter. What you pay will still depend on your plan, your deductible, and your tier. And in fact, some people paid even a little more out of pocket for a negotiated drug this year, not less. So the negotiated price is a tailwind to the whole system, and it may cushion your cost, but it doesn't automatically mean discounts on your individual receipt. Also, this isn't a one-time event. 10 drugs got negotiated prices in 2026, 15 more in 2027, and 15 more are lined up for 2028. The history that makes this really interesting: for 20 years, it was illegal for Medicare to even negotiate drug prices. When Part D was written in 2003, Congress inserted what they called the non-interference clause, language that flat out barred the government from bargaining with the drug companies. Even as the VA was negotiating hard and paying far less. 20 years, that's how long that wall stood before finally the act knocked a hole in it. So whatever you think of the politics, you're living through the first years of a genuine historic shift where Medicare is going to start negotiating drug prices. So now here's the mistake that I don't want you to make. Everything that we discussed, the subsidy ending, the premium bump, all that applies to standalone Part D. Medicare Advantage plans work differently. They bundle your drug coverage in, and they use rebate dollars to make the drug premium look tiny, sometimes zero. So on paper, it can look like a rescue. So this fall, expect to hear a pitch. Someone will show you a flashy Medicare Advantage plan with a lower drug premium, maybe even a gym membership kicked in, maybe some dental coverage tacked on. And sometimes, rarely in my opinion, that's the right plan for a person. I'm not against Advantage plans, but I'm not against Medigap supplement plans either. They fit in different scenarios. But do not give up coverage that you love under traditional Medicare and just to chase a few dollars off a monthly premium. That decision can sometimes be nearly impossible to reverse later when your health has changed and a supplement plan can turn you away. So don't make a permanent decision over a small monthly number. I think that may be one of the most valuable things in this video, so please share that with someone who's about to get that phone call. So now let's make this practical. 4 moves, and they're all free. Number 1, read your annual notice of change. Every fall, your plan mails a letter showing exactly what's changing for the next year. Premium, deductible, covered drugs, pharmacy network. Many people just throw it away, but do not throw it away. I think it's one of the most important pieces of mail that you'll get all year from the plan. Number 2, mark the window down. October 15th through December 7th is when you can compare and switch plans, with changes taking effect on January 1st. That's your window where you have power, so use it thoughtfully. Number 3, check the formulary and run your own numbers. Go to Medicare.gov, use the plan finder, enter your exact prescription drugs that you need and your pharmacy, and compare the total annual cost, not just the premium. If one of your drugs got negotiated down, a different plan might now be your best deal. And number 4, get real help for free. Call 1-800-MEDICARE, or better, find your state health insurance assistance program called SHIP, where trained counselors help you one-on-one at no cost, and they don't sell you anything. If money's tight, call Social Security about extra help, which can wipe out your premium and slash your copays. And of course, if you need help with care, there's the Elder Care Locator at 1-800-677-1116. So let me leave you all where this all began. In Missouri on July 30th, 1965, almost 61 years ago, that afternoon, President Lyndon Johnson sat down beside an 81-year-old former president, Harry Truman, and signed Medicare into law. Truman had proposed national health coverage back in 1945 and had been crushed in Congress by it. 20 years later, he was handed a Medicare card, number 1. He called it a profound personal experience. I think about that sometimes, because everything we talked about today, the drug subsidies, the bids, the formularies, the fine print that's sometimes designed to confuse you, all of it exists on top of one simple promise made to a former president in 1965, that growing older in America shouldn't mean choosing between your health and your rent. I think the rules will continually keep shifting and the headlines will keep screaming. But the promise underneath all of this is that if you read through it thoughtfully, ask the questions, and refuse to be rushed, hopefully you can get good coverage. Please do this for me. Send this video to one person on Medicare. That's a parent, a neighbor, a friend who, is about to weigh these options. And follow along so the next time Washington drops a change on a quiet Tuesday, you'll hear the truth here first. Because a family that understands a fine print is the family that never overpays. I'm Neal K. Shah, and take care of the people who took care of you.